emotional observations or experiences. I would love it if you want to share those. So you can put those in the chat section as well. And we are going to get right into it today. We'll do the same thing as yesterday, where somewhere around 10, we'll take a 10-minute break. And then we'll wrap things up at 11. I wish I had lots more time with you guys, but I think we're going to be able to use the time. So let me go ahead and share my screen. And you guys all should be able to see that. Okay. So we were talking last time about how our nervous system is in most of the time sort of this like range where we refer to it sometimes as a window of tolerance. Any of you who are interested in trauma, you may have seen this from, let me get this back here, sorry. Here we go. The work of Daniel Siegel and Pat Ogden, they talk a lot about the nervous system in the body. And really, when we're talking about forms of trauma, whether it's trauma that's happened early in life, that's been severe, or that's been repeated or chronic, or perhaps all of the three, then you're really talking about a nervous system that has been sort of set for anxiety or set for shutdown. And today we're going to spend a little more time talking about what's actually going on when someone is in that hyperarousal state or in that hypoarousal state, where their alarm system has been triggered. There's something in their environment, accurate or not, that's been assessed to be some level of threat. And the ways that we have as mammals and primates to deal with this. So I'm going to zoom ahead a little bit to, I don't like any of those things. So we're just going to leave this here. So when we're talking about hyperarousal, we're typically talking about something called fight, flight, which you guys are all familiar with, that adrenalized, I'm getting ready to fight the bear, or I'm getting ready to run away from the bear. And actually, if we're talking about a bear, probably you should just try to run away. But there are also two other F's that go along with that hyperarousal state. So let's talk about those for a minute. So the next F is freeze. And this is going to look similar in some ways to what we're going to talk about in a minute with hypoarousal and collapse, but they're different. So freeze can sometimes be described as when you're frozen to try to maybe become invisible, or to not be noticed by a predator or something like that, but you're still at a high state of muscular tension. So a simple way to describe that might be if you've ever been driving at night and a rabbit kind of darts in front of your car and then freezes, in that second that you can see the rabbit, you can tell that the rabbit is very tense, right? And as soon as your car swerves past the rabbit, what does it do? It bolts off again into the grass. So it's stillness at a high state of energy. And it's usually sort of like a midway point between running or fighting or doing whatever other survival strategy that animal's going to use. So we've got fight, flight, freeze. And then there's one more F, and it's nice that these all kind of neatly fit into this little F theme that we have. The last one is fawn. And sometimes we refer to that as tend and befriend. But like I said, I kind of like the F theme that we've got going here. And fawning in this sense means to flatter somebody, to kind of fuss over them, or to be very placating or appeasing. This is moving towards the threat to neutralize it. So this can be things like being very compliant, being very as we said, appeasing, or sometimes even flirtatious. Some people might be seductive or sexual. Both male and female identifying people can use this strategy, although it is kind of socialized more into women. So we may see it more with women, but men and women both can use this. And when I say strategy, I don't mean a conscious strategy. I don't mean someone sat down and came up with a plan. It's an instinctively programmed protocol, if that's a better word, and the brain and body will activate it much faster than the thinking brain can put all the pieces together and actually come up with a thought or a decision. Remember last time we talked a lot about the fact that that middle brain and bottom brain, which is mostly where these functions are going to react and go into survival mode much faster, fractions of a second faster, which in brain terms is a long time, to already kick somebody into fight or flight or freeze or fawn long before their brain has sort of caught up with what's going on. So again, thinking about my professor in that movie theater, he was in the aisle and screaming long before his conscious brain was able to catch up and kind of help orient him and remind him, like, hey, you're not in Vietnam, you're in Columbus and you're in a movie theater and you're screaming. It may, in real time, to an observer, only take a few seconds. But again, in brain time, that's a very long time. And it's important to remember that our brains get good at whatever we ask it to do. So let's talk about that for a minute. Remember yesterday I mentioned that many of us experience some low-level forms of dissociation frequently. And a good example of that is that if you're an experienced driver and you've been, driving the same route to and from work every day, you can kind of check out and be rocking out to whatever song is playing or thinking about what you're going to do when you get home or whatever. And you're largely, probably not completely, but largely disconnected from what your body is doing driving the car. We'll contrast that for a moment with the first time that you were driving, when you were taking driver's ed classes or you just got your license. You were riveted to what you were doing, right? And you were gripping the wheel and you were paying really careful attention. And if your friend was goofing around, you were like, shut up, shut up. You were hyper focused on what you were doing because your brain hadn't done it very often. When we talk about something like learning or practicing, I think we forget how miraculous that really is. That if you practice playing baseball often enough, your brain can actually predict where a spinning orb is going to be on a spinning planet and take into account all the factors that you need to be able to account for to put your hand in the right place to catch that ball. That's incredible. If you had to work that out on paper, that's like, I don't know, calculus or something. I don't even know what calculus is, to be honest with you. I was an English major. But it's amazing what your brain can do if you ask it to do it over and over and over again. Any of you in the audience who played a musical instrument, for example, your brain learned how to look at teeny little dots on a page and translate that into moving your fingers to play this instrument. And the more you did it, the quicker you could do it without even thinking about it. So the good news is our brain gets good at whatever we ask it to do if we're trying to learn how to type on a keyboard or play a musical instrument or catch a baseball. The bad news is that our brain learns whatever we ask it to do with trauma as well. So if you look at this curve again, every time someone's brain kind of bumps up into that hyperarousal space or drops down into hypoarousal, every time that happens, the brain gets more efficient at it. It gets stronger and faster and more powerful. And that is the hypothesis why when we see brain imaging of someone who's been exposed to severe levels of terror or horror over and over again, for those of you in the kid world, especially at an early age, let's say anywhere from 0 to 7, but particularly 0 to 3, you will see that some parts of the brain are more activated than we would expect them to be. Typically in that, remember the hand brain, the middle and bottom regions, we may see more activation there. We may even see more brain mass, more cells have developed, and less activity and potentially even less brain mass in the areas of the brain that are typically involved with the brakes. The part of the brain, like my professor's brain, that could look around and reorient and go, whoa, 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 I'm in a movie theater. Or the part of your brain that glances down and sees that what you just startled away from was a stick and not a snake. So every time it happens over and over, another metaphor for this might be the smoke detector in your kitchen that's a little too sensitive, right? So at first, it goes off when you're burning toast and you're like, yeah, okay, it's not a fire, but I get it. There's some smoke from the toast. Now imagine that it happens over and over and over every time you cook anything. So pretty soon that alarm is going off when you're boiling water. There's no smoke at all. And you're like, ah. And now, if we're going to stretch this metaphor, now it goes off when you're making a peanut butter and jelly sandwich. Something completely not associated with what it originally was supposed to do, which was to detect smoke particles. So The reason that we get people who are wildly overreacting or shutting down at the slightest stimulus, or sometimes nothing that we can even see that's potentially a trigger, it just seems to almost happen by itself. What we may be seeing in those cases are brains that have become so powerful and so efficient at starting this survival sequence that it takes little or nothing to set it off. Now, as I said, the good news about the brain is that it gets good at whatever it does. That's also the bad news when we talk about trauma. The good news, again, which we will talk about more later this morning, is that also means that brains can heal from trauma. So it's kind of good, bad, good, which we'll get back into. Okay, so as I'm talking about hyperarousal, there are probably some things that are coming to mind now, people you've worked with or people you know that have a range of hyperarousal reactions. It's not just they're going to get aggressive and fight or they're going to run away. It could also be that they get frozen. But again, at that high state of tension, you can almost see them vibrating. They are flooded with adrenaline. Or that go into that fawn mode. And for those of you who work with people on any kind of like developmental disabilities setting, or I think we see this sometimes in kids, you may know what I'm talking about, where they go into that overly placating, overly obedient, overly compliant, or sometimes for some people, even something that can look flirtatious or sexual. If you've worked with people that are on the borderline personality disorder sort of continuum, borderline, I think, is actually a fairly poorly conceived diagnosis. I don't think it really captures what might be going on with someone. And there's a lot of stigma attached to that diagnosis in particular. But I will say that people are treated as sexual or flirtatious, sometimes in that constellation of symptoms. And what's not truly being recognized, I suspect, is that they're actually triggered into some kind of trauma or some kind of fear state, and that reflexive flirtatiousness or whatever that we may see is actually fear. I have lots of thoughts about that and why we pathologize that and how we talk about that, especially because a lot of people who are given that borderline diagnosis are women. So that could be a conversation for another time. There are trauma theorists who believe that borderline personality is always related to trauma. I may be in that group. I'm not sure yet, to be honest with you. Anyway, this is just a note here. If you see someone who's been called borderline or has that diagnosis, consider the possibility that A, what they're really dealing with in large part is trauma, and B, these reactions that people find very problematic, and they can be, are reflections of fear, which doesn't mean that there aren't consequences for behavior. It doesn't mean that we don't expect them to behave appropriately, whatever. It just means sometimes it's easier to see what's really going on with somebody if you think about them as being afraid, as opposed to being a pain in the butt. I think this is true for kids. I think this is true for all human beings, actually. Okay, so we've talked about fight, flight, freeze, fawn in that hyperarousal, that red zone. And I really encourage you to try to think about all four of those. I think that's a more accurate, expanded version of what we're seeing and dealing with when someone gets hyperaroused. So now let's talk about hypoarousal. And I'm always really grateful to get to talk to you guys about this one, because in some ways, hyperarousal is easier to deal with, at least in the sense that it's easier to see, right? If someone is throwing a chair at me and calling me everything but the name my mother gave me, or running out the door into traffic, that gets my attention. And people who tend to go into hyperarousal when they're triggered, they're the ones that have all the staffings or all the behavior plans or all the team meetings or whatever it is, because they're making a huge nuisance of themselves. Sometimes they're a danger to themselves or they're a danger to other people. And in a weird way, I'm kind of glad they're doing that, if only because it gets people's attention. It may get them help that they need, right? Hypoarousal tends to fly under the radar. When my business partner and I are consulting with agencies or counties or whatever, sometimes we're asked to do like a case consult, and invariably what we're dealing with, what everybody's grappling with, is someone who goes into that hyper arousal state. And again, that's understandable. They're creating havoc. They're a danger to themselves or other people. So I'm not saying they shouldn't get that attention. I'm just saying that it's the other side of that is that the people who go into hypoarousal are often not a problem. In fact, if I'm talking with a team and they mention, oh, Laura's so great to work with. We just love her. She's such a sweetheart. She's very quiet and she's always smiling. She's always happy. Well, I'm always suspicious of that. Nobody's always happy, right? So I would point out a couple of things. Sometimes when someone who's always smiling, what we might be seeing potentially is someone who is in a state of hyperarousal sometimes. And what we're seeing is the smile of fawning. Or those of you who work with folks with disabilities, you're probably familiar with that phrase, the disability smile. People with disabilities are smart, just like everybody else. And they have figured out that threatening people may be less threatening, or angry people may be less angry, or I may just be more likely to get what I need if I'm smiling and pleasant, right? So to me, that's not the same thing as always happy. And I know that there's some conditions like Williams syndromes where people, do seem to have that positive affect more often. But even so, I don't think any human being is always happy. So I always listen when someone says that. Or when someone says, oh, Laura's so sweet, she's never any trouble to anybody. Really? Never? Never any trouble? I'm trouble to people in my life sometimes. And it makes me wonder, it makes me take a second look. And sometimes I think when we take that second look, what we'll see is that actually I spend a fair amount of the time shut down or checked out. And maybe that's why I'm never any problem to anyone. So what does that look like? First, we're going to talk about dissociation. And we already laid the groundwork for that yesterday. Dissociation, as you remember, just means two things that are usually together are apart. So sometimes at its mildest form, as we said, it's like driving a really familiar route and your attention isn't fully connected to what you're doing because it kind of doesn't need to be. At other levels, dissociation can be something like the words and the feelings are disconnected. So I can tell you a horrifying story, but have little or no emotion while I'm telling it because I'm not feeling it. My emotions are not connected to what I'm saying. Sometimes this can be perception in the body. So if you've ever worked with anybody or known anybody who's experienced usually fairly severe forms of trauma, they may talk about the fact that when it happened or when they're talking about it or when they're in a therapy session or whatever, they can have the feeling that they're not in their body. I've even had people say, it's like I was floating on the ceiling looking down at what was happening. Sometimes people don't have that perceptual element, but they'll just talk about, I'm in the conversation and then I'm kind of checked out. So I lose the thread of what we're talking about. I'm bored. I'm numb. I don't feel anything. I'm cold. I'm sleepy. I've noticed clients do this sometimes when they're yawning a lot. That tells me sometimes that their energy level has dropped and they're kind of not aware of their body or not feeling a lot in their body. Those of you who work with kids, you may have heard kids talk about things like, when the bad thing was going to happen, I would leave my body and go into my stuffed animal. So these are all different ways that interoception, that sense of being in our body and feeling what's happening inside our body, that's normally kind of knit together. We can feel our body, we can feel our feelings, we can be aware of our thoughts, are now separated. At its most extreme forms, as I said yesterday, that's when you might hear things like people are doing things they're not aware of, and they sort of come to, as it were, much later in the day. So big chunks of time are missing, or they're in an environment that they don't remember going to, or they went and bought clothes they don't remember buying. That, in my experience, is pretty rare, but there are instances where people report that, and I've had a few clients that report experiences like that, but that's pretty unusual. So now let's talk about collapse. And collapse is sort of the physical version of what happens when someone is dissociated. Collapse is when there might be limpness or stillness. And remember, we talked about we were going to contrast that with freezing. Freezing is at a high state of energy, ready to take off, right? As soon as there's an opening, I'm out. Collapse or limpness is like, I'm done. I'm not putting up a fight. I'm waiting for the next thing to happen to me. So when I taught this in grad school, I would sometimes show a video of a coyote that had caught a rabbit, right? We talked about the rabbit in front of your car. Now the coyote has the rabbit and she's just limp, right? She's just, ugh. Because if you're about to be eaten by a coyote, you don't want to stick around for that, right? So prey animals often have that sort of reflex of, if I've tried everything and I can't get away and I'm about to be killed, I just kind of check out. So collapse and freeze can look at first glance similar, but they're at absolutely opposite ends of the range of what someone is doing. Someone has described these two states as hyperarousal is when you've got a chance to survive, and hypoarousal is when there's a life-threatening threat and you can't do anything. Learned helplessness may also be something that we see, that when someone has been confronted with something so terrifying or so overwhelming that they check out, that they've learned to not try to do anything. So in future situations where it seems like they could get away or they could set a boundary or whatever it is, they've already gone all the way down into that collapse state, and they become very passive and don't do much of anything, which of course can then lead to the risk that they become re-traumatized by some new trauma because they're not able to use those survival strategies that they might have access to in that hyper-aroused state. I don't need to go on and on about this. I think you guys kind of get it, but I wanted to acquaint you with, again, a wider range of what someone might actually look like when they're either in that hyper or hypoarousal state. And I think it also is a good way of reminding ourselves that trauma really is about the body. It's not the thoughts, it's not even the emotions really, although that's part of it. Emotions are in our body. Trauma is an entire nervous system experience and can become an entire nervous system barrier or problem to being present in your own life. When we go all the way back to that quote from Pierre Genet about trauma is a disease of not being able to be here. Yeah, now we can kind of see that graphically, right? If someone is spending most of their time either in that red zone or that blue zone or both, they spend very little time in that window. And because the brain gets good at what we ask it to do a lot of, we will actually see people's windows shrink, like that smoke detector that becomes too sensitive. So it takes almost nothing to set it off. That really limits what you can do in that kitchen without setting everything off. So one of the ways that we can think about trauma therapy, for example, how we trauma therapists talk about it, is trying to expand the window of tolerance so people can live more of their life integrated and present. Okay, so moving on, I have a couple of slides that talk about this in slightly different ways. We're gonna skip this. If we've got time, we'll go back to it. But I wanna talk about this slide, and actually this slide should have a credit at the bottom of it for Deb Dana. She is a therapist who works closely with polyvagal theory, which we will not have time to do today. That is a different trauma training that we could do. Suffice it to say that that polyvagal theory works with the nervous system of the whole body. And so in her work in therapy, she works with people getting familiar with what's going on in their body when they're in that red zone or blue zone, and strategies to come back into their window of tolerance, to use our metaphor in the brain, to turn off the alarm system that's going off for no reason and let all of the parts of the brain, all of the functions of the brain work together again. So someone knows who and where and when they are and what's happening and what's not happening, and their nervous system is functioning in that sort of normal range again. So in her book, she uses this worksheet with clients, and I've reproduced it here just to have another way to talk about this. And we'll pick up with this again when we talk about the calmer skills later this morning. So she works with her clients to fill out, let's just look at that middle section with those boxes. noticing what their sensations, feelings, and thoughts are. And you'll notice the order in which she talks about that. And that's the same order that I always use with my clients, starting from your feet, going up to your head, what's happening in your body. Because again, the brain mechanisms for either revving me up for fight, flight, freeze, fawn, or shutting me down into collapse are much faster than my thinking brain. And it's often easier to see it in my body. So for example, if I learn to check in, I may notice that I feel heavy, I feel cold, I feel shut down, I'm yawning a lot. I may notice that collapsed or dissociated state in my body much more easily than to try to notice that my brain has already shut everything off, right? That's so fast that I'm always going to be a little bit behind. So I start with the body. That's easier to notice. And things happen in the body much more quickly. So I'm not going to bore you guys with vagal theory. That might be something we can talk about during the break if you're interested, or again, that's kind of another training. But when I'm feeling okay, so if you look at this first sort of row here, don't worry about ventral vagal. Engagement zone just means I am able to interact with the world. So I'm in my window of tolerance, whatever that is for me. All the different functions of my brain are working together. So my body is not hyper aroused, my body's not hypo aroused. I'm taking in the stimulus around me and dealing with it appropriately. I am able to be social and engage with people, whatever that is for me, right? So if I'm some big extrovert, I'm engaging a lot. And if I'm more introverted, I'm engaging less. And if I'm on the autism spectrum, maybe my way of engaging looks different than other people's. But whatever's normal for me, that's where I am. My body feels whatever version of relaxed, calm, whatever that is, awake. My feelings are pleasant to neutral. I feel like things are okay. And my thoughts reflect that too. I'm thinking about whatever's going on around me, or I'm thinking about what I'm doing, or whatever that is. Now, the code word there is something that I use with clients, or sometimes when we're working with staff, just as sort of a shorthand, right? So that just means, what word would you be able to use with yourself, or if you're talking to a friend or your therapist or somebody, what word sums up when you're in this state? So it might be like loosey-goosey. I feel loosey-goosey, everything's okay. And then the next one, you kind of see where this is going. What does it feel like when you're in that fight, flight, freeze, fawn mode, right? What's going on? So for me, my skin's very pale. I'm one of the pale people. So I can feel my cheeks flush, and I can feel my muscles shaking, and I can hear my voice shaking. That's the sensation that I'm able to notice in my body. My feelings are, I might feel frantic or angry or terrified or whatever that might be. And my thoughts might reflect that. So my thoughts might be like, oh, I've got to get out of here, or I can't believe this person is doing this. I've got to stop this, whatever it is. And then again, the code word, whatever shorthand is useful. Sympathetic, by the way, over on the far left, doesn't mean sympathizing with another person. This means the sympathetic nervous system has been engaged. One way to think about the sympathetic nervous system is, just to break it down, sim means with, and pathos means feeling. So you're going with the feeling. A shorter way to say that might be, you're hitting the gas, right? So it's that activated, adrenalized, I'm going to deal with this by fighting or fleeing or whatever it is. And the code word for our purposes today could be like red zone. I'm in the red zone. There you go. And then the last one, again, dorsal vagal refers to polyvagal theory. Don't worry about that. But now we're in hypoarousal. So what does that feel like when you're collapsed, when you're shut down, when you're limp? And that might be, in my body, I feel heavy, I feel sleepy, I don't feel my body, I feel hopeless, I feel numb, and my thoughts reflect that as well. People will sometimes report that they don't have very many thoughts. Their brain just seems to be kind of offline. So you guys sort of get how this works and how you can start mapping this. The reason that I've included this slide is that I really encourage you, after this training today, to do a little bit of this for yourself, to really start to list, what does it feel like in my gut, in my body, in my muscles? when I feel safe and relaxed and I can be however social I typically am with people, open to the world, but with boundaries, right? What does it feel like? What are my emotions like? What do my thoughts sound like when I'm hyper aroused, when I'm in that red zone? What do my sensations and feelings and thoughts seem like to me when I'm collapsed and shut down? And one of the things I like about this is that it also helps to depathologize people's experiences. All of us have programmed into us, even the most simple organisms on earth, some version of how to engage with the environment and how to withdraw from the environment. Even if you're like an amoeba, right? You can sort of spread out when the conditions are good, and you pull, you contract when they're inhospitable. All animals to varying degrees have some versions of get away, fight, shut down, whatever it is. And as I keep reiterating, these are faster than thought. So I always work hard with clients to honor these, to recognize that they are part of our birthright as animals, as mammals, that they are not bad things to do. The problem with trauma, if you go back to that analogy of that overly sensitive smoke detector, is they're just going off at the wrong times, right? And by repeated working with recognizing what's going on and coming back into that window of tolerance over and over and over, we may be able to start to reprogram that, so that over time, with lots of practice, people will find that their window of tolerance does get wider. They don't get as triggered as quickly and easily, or if they do, they're more able to recognize what's happening and use strategies. Typically, it might be movement, it might be muscle work, it might be breath work, it might be self-talk. There are a lot of different things people can use to come back into range. And the more that happens over and over, the brain gets good at whatever we ask it to do a lot of. They will start to see that it's kind of like that image that I used yesterday of, if my dog is running around on the yard when it's soaked with rain, it tears up the yard. And after that's happened, you might be able to see those ruts in the grass, right? Well, now imagine that I don't let the dog out on the yard at all for months, years. Eventually, the grass would grow in. For some people, to the point that you can't ever see where those tracks had been dug up. For some people, and this is something people always ask me, can trauma ever be completely erased? For some people, probably not, to be honest with you. Again, depending on how early, how prolonged, or how severe the stress is. For some people, they will probably always be triggered a little more easily than they might have otherwise. It might take longer for them to reintegrate and come back into their window of tolerance than it might have otherwise. But I do think that we can never limit the amount of healing a human being can do. I don't think we've ever reached the end of what human potential is. So I always assume, no matter how traumatized someone is, that healing is possible. Will you have a brain exactly like the one they would have had otherwise? Maybe not. So moving ahead, this is really a lovely quote for summing up everything we've been talking about. And some of you may be familiar with Bruce Perry if you work with kids. He's been in Columbus a number of times, so those of you in surrounding areas may have heard about trainings that he's done. He is probably the preeminent expert in the world on childhood trauma. And as we talked about yesterday, what's true is true for most brains most of the time. People usually want to teach other people from the top down, but the brain actually works from the bottom up. And this is what he means. What he means is, if your brain and body have already started that sequence of hyper or hypoarousal, you've got to work with that first. Another way to think about it might be, if you burnt toast and your smoke detector is going off, what's the first thing you do? You get the toast out of the room, right? You throw it away or throw it outside or whatever you're going to do. You clear the smoke out of the room, and then you work on resetting the smoke detector, right? If you just stand there screaming at the smoke detector, nothing changes. But what tends to happen is people want to start from the bottom, from the top down. Now, again, this isn't completely how the brain works, but this is useful enough for how we're talking about it today. If you think about kids in a classroom, or an individual with developmental disabilities, again, put them in the position of my professor in that movie theater. When my professor was screaming and terrified, people might have wanted to say things like, well, you're going to lose all your privileges, or do you want to go to the timeout room? In other words, they would be asking my professor to think about consequences, asking him to use the function of his brain that was most offline. Asking someone to think when they're terrified, right? It's not going to work. The way that the brain is set up means that you've got to help the brain feel that conditions are safe before everything can come back online. And then if you want someone to think about consequences or the impact of their behavior on other people or whatever, then they can do that, right? But until that happens, until you clear the smoke out of the room, that smoke detector is going to keep going off. That's how it works. And so as we proceed with the rest of our time together, we're going to operate in that order, that we've got to clear the burnt toast smell out of the room before we can expect that the smoke detector is going to do anything different. We've got to work with people from the bottom up, not yelling at them or scolding them or explaining things to them from the top down, asking them to use logical functions that are probably not available to them in that moment. Okay, and again, we're going through things very quickly, so if you have observations or things you'd like to share from your experience or questions about anything, or you want me to go back to something, go ahead and put that in that chat section, and we will be doing that as well. Okay, so what is trauma responsive care? I actually don't want to use the slides for this, that slide, so we're just going to talk about this. If we want someone to feel safe enough to have all of their brain functions working, then we need them to feel safe. That's the first thing. Not be safe, but feel safe. I'm actually going to pause the share here for a second because I just want to talk to you guys. So if you think about what trauma is feeling unsafe, and it's feeling out of control. If you feel unsafe, but you're in control, then that might be something that you chose to do, like skydiving. Why is skydiving exciting? Because you're not totally safe. You're not totally, you're 30,000 feet in the air, however high you are, but you have a feeling of control over it, right? That's the heart of trauma, really. That control has been taken away from me and I am profoundly unsafe, either literally, physically, like in that car accident that I described, or I'm emotionally overwhelmed with stress and terror and horror, like I'm a vulnerable kid watching domestic violence unfold in front of me, something like that. So if any of you who've done any sort of trauma-informed trainings, trauma-informed care, SAMHSA training, stuff like that, you'll notice that all of those trainings, what I've worked with, like the sanctuary model and some of the stuff SAMHSA does, if you look at all the things that they talk about that people need, you can sort of break them down into those two categories, helping people feel safe and helping people feel in control. Now, in control doesn't mean in control of everyone else. I'm now the boss of everybody. In control means I'm in control of myself. And what that really means is my brain is all the way back online. I can appropriately take in information around me. I can make choices and decisions about what I'm going to do. I can choose to pick up this coffee cup and I can choose to set it back down. If I don't have those choices, either because they've been taken away from me or because my brain is just in safety mode and that alarm is going off, wah, 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 and I can't think through anything, then I'm really not in control of myself. My professor was not in control of himself when he jumped out of his chair and was screaming. That was not a choice that he made, right? So most trauma-informed care models that you look at have those two pillars: people feeling safe, people feeling in control, which makes sense. With trauma responsive care, which, as I said, is really trying to go to the next step after being informed about trauma, trauma responsive care says the best way to do that is to help people feel connected. So trauma responsive care is helping people to feel safe, connected, and in control. We added that middle piece. So what does connected mean? Connected just means that you feel that you are in the presence of another human being who sees you and cares about you. That could be your best friend of 30 years. That could be the teacher or the staffer or whomever that you've worked with for a year and built a good rapport with. That could be someone that you've just met who's speaking kindly and gently to you. We can start helping people to feel connected immediately, even if this is the first time that we're meeting them. Obviously, if you've got a long relationship and you've got that context, that's even more powerful. But think for a moment if you had, I don't know, been through some disaster or an accident or something, God forbid, and you were talking to the emergency room social worker or the EMT who is helping you or someone like that, the first person on the scene. How would you want them to speak to you? Would you want them to be rattling off information? Would you want them to be demanding a lot of information from you? No, to the extent possible, you would want them to be kind and reassuring. And even as I'm saying this to you, you probably notice that instinctively I'm kind of like, kind of bringing my energy down slightly to describe what that feels like. Someone who's got a comforting, serene, calm vibe with you, to use the very unscientific word for it. That's what you would want. And everything else could happen after that. So when we talk about helping people to feel safe, connected, and in control, that's really what we mean. Now, why is this important? Why does connected even fit into this? Especially if you're like, I really need to get this person to stop punching themselves or hitting this other person or running into traffic. Well, obviously, whatever it is you need to do to keep someone physically safe, that's what comes first. So if you need to, block someone from running out the door or intervene so they don't keep hitting someone else, you should do that. Immediately after that, you want to try to get their brain all the way back online, right? You don't want them to stay in that hyper or hypo-aroused state, obviously, right? So helping them to feel connected does the following things. To talk about what connected does, we have to talk about what fear does in the brain. So remember we talked about there's something that happens in the environment, something that anybody might feel is dangerous, like a bear's charging at you, or maybe it's a trigger that nobody else would feel dangerous. Like no one else in that movie theater felt like they were literally in danger watching the movie, but my professor did because it triggered a time that he had actually been in danger. So something like that happens, okay? And largely, although not necessarily always in the amygdala, something gets triggered or set off that the amygdala says, I am not safe. The amygdala triggers a chain reaction of things through the middle and lower brain down into the body. It releases, among other things, norepinephrine and cortisol in the brain. And that triggers the release of cortisol and adrenaline in the body. You've got your adrenal glands that sit on top of your kidneys. You get the signal from your brain. The adrenal glands start pumping out adrenaline, and that's that fight or flight that most of us can relate to. Sometimes our muscles are actually shaking, and that's because the muscle fibers are twitching. They're being flooded with cortisol and adrenaline to get you ready to do whatever you need to do. Now, why do we care about this? Why am I going into all this detail about brain chemistry? Because the brain is unfathomably complicated in terms of all the things it can do. I saw an estimate once of all the different functions your brain is going to do in your lifetime. And it was some crazy number that I couldn't even comprehend, like 11 jillion, right? There are infinite combinations of things that can be happening and cells that can be lighting up in your brain at any given moment. But the brain is also organized on some really simple principles. Here's one of them: on, off. That's it. One of your brain cells is either activated or it isn't. When your brain starts something, it also has to have a way to stop it. There's an on switch and an off switch. Otherwise, once I started scratching my nose, I would never stop until my nose falls off, right? And in fact, if you look at some neurological disorders like Parkinson's, that's a good example. Parkinson's can make both the on and the off switch hard to manage. The brain's not doing it right anymore. So it can be hard to make a movement. And once that movement starts, it can be hard to stop it. That's why we see all that weird movement with someone with Parkinson's. Okay, so that means that if the brain has an on switch for fear, which chemically speaking is, among other things, norepinephrine and cortisol. Those are the chemicals that your brain starts flooding itself with when you are afraid or threatened by something. Well, if it has an on switch, it has to have an off switch. The off switch for fear is, among other neurochemicals, dopamine and serotonin. You've heard about those. They're involved in lots of different things. Serotonin seems to be involved a lot with mood regulation, with learning, with memory, lots of different things. Dopamine is largely involved with things like your reward system and what we find pleasurable. So there are lots of different ways that our brains can release dopamine and serotonin. During the pandemic, we were all acutely aware of that. When we were all terrified and under a tremendous amount of stress, what did people instinctively do? Very few people settled down on the couch for their delicious kale salad. Maybe some of you guys did. You're a better person than I am. Most of us went straight for the comfort food. Why do we call comfort food comfort food? Well, anything can be depending on your association with it, right? But generally speaking, if I say comfort food, you think of food that has a lot of fats and a lot of sugar and a lot of salt. Why? Because fat and sugar in particular release dopamine in your brain. That's why we crave those things when we're upset or stressed. And of course, if we have some association with it. Grandma used to give me ice cream after school. I have a really positive association with that. So not only does it release dopamine and serotonin because of all the sugar and fat, but also I have this emotional memory connected to it. Great, right? So we instinctively go for things that will increase the amount of dopamine and serotonin in our brain when we're stressed. Why is that? Because if you have, let's say, cortisol in your brain, and your brain starts releasing a lot of dopamine and serotonin, I'm doing kind of like a little Pac-Man move here, the chemicals dopamine and serotonin literally break down cortisol. They break it down, they make it go away, they attack it. So your brain's flooded with dopamine your brain's flooded with cortisol and norepinephrine because you're afraid. You start pumping out the dopamine and serotonin and it starts breaking it down and your mood starts to shift, the feeling starts to shift, and your brain can come back online and you can be thinking. So you can look around and go, oh, I don't need to be screaming incoming because I'm in a movie theater. Or, oh, this staff person is with me and I should talk to them instead of continuing to punch this person in the face, right? So there are lots of different ways that the human brain can release dopamine and serotonin. We've already talked about some of them. For some people, food is really powerful. Anything that we find enjoyable. So watching TV, online shopping, playing little video games on our phone, gambling, sex, most street drugs. Those are all the things that human beings tend to find really fun. But one of the most powerful and quickest ways to flood the brain with dopamine and serotonin is love. Kind connection, validation, right? One of the things that made, I think, the pandemic so difficult was that it was so hard to get to feel connected with the people that typically make us feel that flood of dopamine and serotonin. So the off switch for fear is love. In fact, that's my favorite verse from the Bible, right? From John. Perfect love casteth out fear. Love and fear can't be in the same space together at the same time in your brain. Now, again, love might be someone that, has been close to you for 30 years, or it might be that social worker or that EMT or that firefighter or neighbor that you've never met who's speaking to you kindly in those moments of fear and stress. It just means you feel valued, you feel validated, you feel seen, you feel comforted, you feel cared about. That's what connected is. And as we said, the fastest way to get the brain to do what we want, to turn off the smoke alarm or the smoke detector, and to bring all the functions back online so someone can talk and explain what's going on, so they can think, so they can make decisions, so they can weigh consequences, all of the stuff we want someone to do. To those of you who work with kids, maybe in a classroom, to get the kid to remember that new skill we've been working on, or whatever it is. The brain has to be online and integrated and in the present moment to be able to do that. And the fastest way to do that when the brain's been knocked offline by fear is safe, connected, in control. So that is why we sometimes say that trauma responsive care is sort of the next step. It's going to get you to where you want to go with using brain science as an accelerant, right? To make it work faster and more efficiently. Now, it may still not be fast, right? When someone has had a lot of trauma and a lot of stress and their brain is overreactive, let's say, to stress, then it may still take them a long time to come back into that window of tolerance. Remember, helping people's brains experience getting activated and then calming back down, it needs to happen over and over and over and over again before it starts to overwrite, if you will, some of those protocols of freak out right away. And so some of you have worked with clients where you know once they get set off, that's your day. That's what you're going to be doing, right? But if we're focused on safe, connected, and in control, I do think that that gets people online with their brain the way that we want, faster and more efficiently. So the last thing we'll talk about, and then we'll take our break, is who needs trauma responsive care? When should we be doing this with someone? Well, obviously, if you see someone who's already triggered into their trauma, they're already in that red zone or in that blue zone, they're hyper aroused or they're shut down or whatever it is, then you immediately want to start working on helping them to feel safe and connected and in control. But remember what Bruce Perry said in his slide, that people want to work from the top down, but actually humans' brains work from the bottom up. That means everybody. And if you are working with, in this case, let's say developmental disabilities, remember what we said, that upwards of 90% of people with some form of a developmental disability may have experienced traumatic levels of stress at some point in their lives, either that big T event kind of thing, or that cumulative little t stress. So when we look at the kid world, and that's where I come from, the mental health child world, we've known for a long time that we should treat trauma as a universal precaution, that kids are so vulnerable that we should treat them as if they've experienced a trauma. And by that, I don't mean send every kid to trauma therapy. I just mean assume that every child that you're working with in your program or center or whatever may have had traumatic levels of stress. So in other words, you want every kid to feel safe, connected, and in control before you ask them to do anything else, so that they have the best chance for their brain to be fully online and fully working to whatever capacity is normal for them. You treat it as a universal precaution. Remember what that means. Universal precautions are, if I'm at your, I don't know, group home and I get a cut, staff are not just going to come over with a Kleenex and be like, oh, here, let me clean that up for you. What are they going to do? We all have to go through first aid training and all of that, and they're trained to put on a pair of gloves, right? Why? Because I might look okay, but I might have an illness that maybe neither one of us are aware that I even have, that could be transmitted through my blood. And if that staff person has a little scrape or hangnail or cut or something, they could get that illness without either of us even knowing. And it's not practical to say, hang on, Laura, I'm going to go get you tested for hepatitis and HIV, and then you can have that Dora the Explorer Band-Aid. It's probably Paw Patrol. I know Dora the Explorer is really old. So let's say Paw Patrol. I can have that Paw Patrol Band-Aid once we've tested your blood. Well, that's ridiculous. That's going to take weeks. And you can't just assume I'm okay and hope for the best, because those consequences could be catastrophic. They could be fatal, right? So the smart move is to treat me as if I have something that could make someone sick. We're all living this now with masks, right? Presumably, most of us walking around with a mask on at any given moment don't actually have the COVID virus inside us. But if we do, that's going to help protect everybody else. So In the child welfare, child mental health world for years, decades now, we've treated trauma as a universal precaution with kids. Assume that that's what we might be dealing with along with everything else. And that's how we say trauma responsive care should be for everyone. So again, let's use the example of someone with a developmental disability or someone who's on the autism spectrum, whatever. Treat them as if they need to feel safe, connected, and in control before we ask them to do anything else. The good thing about this is that, much like putting on a pair of gloves, it's not going to hurt me, right? If you're my staff person and you put on a pair of gloves, even if it turns out you didn't need to, it's not invasive, it's not intrusive, you're not hurting me, and it costs fractions of a penny, right? So the same thing with trauma responsive care. If I were in the room with you guys and I said, raise your hand if you don't ever want to feel safe, connected, and in control of yourself, you would prefer to feel terrified, alone, and powerless. Very few people choose that. So even if it turns out, again, let's say that I have a developmental disability and you're working with me and you make sure that I feel safe, connected, and in control, then even if it turns out I'm that lucky 1 in 100 who really had no significant traumatic stress in my life ever, great. I'm still going to benefit and enjoy feeling safe, connected, and in control with you. You're not doing anything intrusive or invasive or harmful. So who needs trauma responsive care? Everybody. Everybody. When we come back from our break, we will talk about how we can use the calmer skills to put us in the best position to help the person we're working with, or even a colleague or a friend or anybody, to feel safe, connected, and in control with us. So we're going to go ahead and pause here. I'm going to check to see if there are any comments or questions. And this is a good moment to toss those in there, and we will come back at, let's see, it's 10:02 on my calendar. On my clock rather. So we will come back at 10:12. So I will see you guys in 10.